interesting case with some review of literature. A 19-year-old male patient presented to Ishapi Hospital. He is known beta thalassemia major for routine examination. On ultrasonography, we found bilateral adrenal lesions for which the clinician asked for CT adrenal protocol. Here is the non-contrast axial cuts of the CT, and here we can see the bilateral adrenal lesions with diffuse hepatosplenomegaly and the increased attenuation of the liver reflecting iron overload. Here's the contrast-enhanced venous phase, and it's obviously that the adrenal lesions are enhancing. As we see, we have bilateral adrenal lesions with peripheral foci of calcification. The right one was about 5 centimeters in maximum dimension of initial attenuation 45 Housefield units that became 66 on venous phase. The left one shows areas of gross fat attenuation, and it's about 3 centimeters with an initial attenuation of 50 Housefield units that become 70 on the venous phase. All show wash out less than 50%. Let's have some brainstorming. What do you think about the differential diagnosis? Are they incidentalomas or adenomas for being incidentally discovered? Of course, that is easily ruled out by the dimension of the lesion. They are more than 3 centimeters, and they are of low washout, so this is easily excluded. What about being metastatic disease or neoplastic lesions? Actually, metastasis to adrenal glands is quite common, especially from sites like breast, lungs, GIT, kidneys, or melanomas. Still, we do not have a primary in our case. Pheochromocytoma could be an option, but here the patient was totally normotensive, so this is not matching with our clinical data. Myelolipoma could be accepted for the left adrenal lesion for the gross fat attenuation. Still, it does not explain the larger right adrenal lesion, so we need another clue. Let's have a deeper look on the CT venous phase, and this time I want you to focus upon the basal chest cuts. Yes, here, as we see, we have bilateral paravertebral enhancing soft tissue masses reflecting the typical site of the extramedullary hematopoiesis in thalassaemic patients. Putting all the puzzle particles together, we can come up to the final diagnosis. We have incidentally discovered adrenal lesions in a rather normotensive patient and who is known to be beta thalassemia, and he has the typical appearance of the extramedullary hematopoiesis with hepatosplenomegaly and the bilateral paraspinal lesions. So we can come up to the extramedullary hematopoiesis in the adrenal glands. Simply, extramedullary hematopoiesis is a compensatory mechanism that occurs due to a chronic state of anemia, where the blood production occurs outside the bone marrow. That could occur due to infiltration of the bone marrow by myelofibrosis, leukemias, lymphomas, or in cases of other hemoglobinopathies, like in our case, thalassemia or sickle cell anemia. Blood production during the fetal life occurs in liver and spleen initially, and that's what we call the physiological extramedullary hematopoiesis, and that explains why liver, spleen are the most common sites of extramedullary hematopoiesis later on. While the most common site for extramedullary hematopoiesis in thalassaemic patients in the chest are those paraspinal soft tissue lesions. That's to say that this chest X-ray is a totally normal one for a thalassaemic patient with those posterior mediastinal paravertebral soft tissue opacities. What about the adrenal glands? Adrenal glands is a rare site for extramedullary hematopoiesis that's usually associated with patients with beta thalassemia. How? Either that adrenal glands have rests of hematopoietic stem cells, like in case of liver and spleen, that were reactivated later on, or by hematological spread, or even by direct invasion of those cells from the adjacent bone marrow of the vertebral bodies to the nearby adrenal glands. Anyhow, we have, according to the Canadian Neurological Association Journal, that describes an adrenal extramedullary hematopoiesis as a case report, and also according to the Royal College of Surgeons of England, that describes another case of extramedullary hematopoiesis in adrenal glands as a rare case, and it was also associated with beta thalassemia. To sum up, those three tables summarizes all the cases of adrenal extramedullary hematopoiesis that was reporting according to PubMed and Medline from 1920 till 2018, and there were only 21 cases. And guess what? 15 cases of them were associated with patients with beta thalassemia, and 6 cases only were associated with other hemoglobinopathies. Most of the cases were presented with irrelevant clinical symptoms. They were all complaining of vague abdominal pain or symptoms related to the size of the large adrenal lesion. Most of the cases were treated surgically by adrenalectomy, while 2 cases were conservatively managed. They were followed up by blood transfusions, hydroxyurea, and they found that the patient remained asymptomatic, so they come up to the diagnosis of the adrenal extramedullary hematopoiesis with no need of surgical intervention. And here is the home message. Whenever you found a thalassemia patient with those adrenal lesions and the full-blown picture of the extramedullary hematopoiesis in the liver, spleen, and the chest, you can think first of all of being components of this generalized process before thinking of something suspicious that will lead the patient to undergo unnecessarily surgery. Finally, I'd like to highlight 2 other less common sites that can mimic cancerous conditions, where, like in the subpleural lesion here, it can cause even remodeling and erosions of the underlying grip, and this was proven only to be an extramedullary hematopoiesis. Another critical site is the intraspinal canal, where, as we see here in these 2 images of MRI, the right one is the T2 sequence, and the left one is the T1 post-contrast fat set. We have these enhancing intraspinal lesions causing compression of the spinal cord. And they also cause marked narrowing of the left neural foramen. And of course, here surgery is mandatory for decompression and not for being a suspicious lesion. Thank you.